Welcome to the University of Vermont College of Medicine and Community Medical School. I'm Dr. Jan Carney, Associate Dean for Public Health and Professor of Medicine here at the College of Medicine. Tonight, I am delighted to welcome Governor Howard Dean, with whom I was fortunate to serve as Vermont's Commissioner of Health. We worked together on a variety of important health initiatives, including the expansion of Vermont's Dr. Dinosaur program, which provides low-cost or free health insurance for eligible children under 18, and preventing tobacco use among youth in Vermont. The College of Medicine is honored to have Governor Dean deliver a special presentation on healthcare reform as part of the Spring 2013 Community Medical School Series. We are delighted to have so many people here in attendance tonight, and we also have people in our Sullivan Classroom and nearby Medical Education Center. So welcome, and I hope you enjoy the presentation.
Good evening, everyone. I'm Theresa Albertini DePalma. I'm the Senior Vice President for Marketing and External Relations at Fletcher Allen Healthcare. And on behalf of Fletcher Allen, I am also pleased and honored to be able to welcome Governor Howard Dean to this wonderful, wonderful place. I, too, like Dr. Carney, had the privilege of working for Governor Dean. For me, it was during the mid to late 1990s. And for those of you who are history buffs, or for those of you who have followed the ebb and flow of national healthcare reform debates in our country, you may remember that that was at the beginning of the time right after the Clinton reform health plan saw its last day. Not a very successful end to that whole effort, and I had been a part of that at that time, working for Senator Leahy, and got to know Governor Dean at that time. And you may remember that Vermont also at that time had an effort to pass a universal access and coverage plan that didn't go as well as we had hoped it would. But if you know Governor Dean, you know that that was no deterrent to him. He assessed his options and determined that he was going to do what it took to get more Vermonters the insurance coverage and the health care that they needed. And he put forward a very bold plan to expand the Medicaid program, and in doing so did reduce the number of uninsured in Vermont. And that is just one of many, and Dr. Carney spoke to a number of other ways that the governor had a true impact on Vermont's healthcare system. It was great fun working for the governor, but you always had to be on your toes. I found that he was always about 10 steps ahead of me, at least, and by far always the smartest person in the room. That's one of his strong points. I can also tell you, though, that there's one virtue that he doesn't possess, and that's patience. And you may hear a little bit of that from him this evening as he's berating those of us who work in the provider world to do it faster. You all know the old adage, Rome wasn't built in a day. I think Governor Dean's reaction to that is, why not? You know, if you just, let's get a plan. I want to see it by Wednesday. Today's Tuesday. I want to see it by Wednesday, and we're gonna build Rome in a day. So he's not a patient man, but he is a tenacious man, a good man. And as a physician, let's not forget, he is a physician. He always has central to his focus what's best to be able to respond to human need and to respond to the patients. So we welcome you. We are honored to have you here, Governor, and I look forward to hearing what you have to say tonight.
By now, you may be wondering if he'll ever get up here. I'm Mark Levine, and I'm a professor of medicine and an internal medicine physician and educator here at Fletcher Allen and the University of Vermont College of Medicine. And I actually get to do the more formal aspect of the presentation in providing you with a little bit of biography about Governor Dean. Although I suspect in this Vermont audience, there's very little to say that you don't know. But it's a great honor to be introducing someone who I suspect needs a little introduction, but who I've known for well over 30 years. So I too worked for Governor Dean, but as you'll learn, in a fairly different capacity. In the before Vermont portion of his biographical profile, Governor Dean was, of course, a political science major in his undergraduate college career at Yale, and then went on to Albert Einstein College of Medicine to get his MD degree in New York City. He came to Vermont to pursue internal medicine residency, and at that time, I came to Vermont a year later, so he was truly one of my mentors, and one could say I worked for him. And he remained in Vermont for the remainder of his medical career and essentially has really never left. He practiced general internal medicine in Shelburne, but already then was an active elected public servant at that time in his career. We're all aware he was the second longest serving governor in the state of Vermont for a 12-year period, and we're also aware that he chaired the Governors Association during that time. We recall how he firmly placed Vermont on the national political map, first in his role as a governor, who really did expand access to health care and was very innovative in health care, as you've already heard, and of course, obviously subsequently in 2003, when he became a presidential candidate. As a candidate and then as chair of the Democratic National Committee, Governor Dean is credited with substantially changing the entire way candidates approach getting elected in this country, for any office, but certainly for the office of president. He implemented the 50-state strategy. He was very innovative with internet-based fundraising strategies and other 21st century campaign tools. You may not know that in his current life, he's a part-time consultant independently, focusing on healthcare, his devotion to early childhood development, alternate energy, and the expansion of grassroots politics around the world. Per the organizers of this session, I am required to inform you that the event is sponsored by the UVM College of Medicine. The use of the University of Vermont's facilities for this event does not constitute an endorsement of the content of this event by the university. I can think of few others who possess the track record in the health arena and the insights and perspectives to educate us and interact with us surrounding the topic of tonight's presentation. Please join me in welcoming Governor Howard Dean.
Thank you. It's great to be back in Vermont. Thank you for the very kind introductions. Theresa was not entirely correct. Usually the people who end up working for me are smarter than I am. This is why they make me look good. Mark actually went on to be the chief resident, so he was much smarter than I was. So a couple of things up front. First of all, it's great to be back. It's the largest crowd I've had since I rendered a list of states at the end of the Iowa campaign. I really appreciate it. Second of all, would it be easy? I can just move over to here. How about that? Okay. Second of all, I have to give Mark a history lesson. I am actually not the longest-serving governor or the second longest-serving governor in the history of the state of Vermont. I'm the longest-serving governor in the history of the state of Vermont. What most people don't know, and if Frank Bryan were here, he would set us straight. What most people don't know is that Vermont was an independent republic for 14 years before we became a state. I love to mention this in Texas, since they have such an inflated opinion of themselves. We were an independent republic from the time since 1777, when Vermonters in Windsor declared our independence from Great Britain, until 1791, when we got admitted into the Union. And I'm just going to put in a shameless plug for a book that's probably out of print, but it's one of the great books I've ever read by a guy named Frank Smallwood, who had the unfortunate history of being both from Dartmouth and a Republican. But he's actually a fantastic guy. He was a state senator in the Vermont State Senate, and he wrote a biography of Thomas Chittenden. And for anybody interested in Vermont history, you ought to read it. It's the best book I've ever read about Vermont. So the fact of the matter is that the only governor that served longer than I did was named, in fact, Thomas Chittenden, the first governor of the state. They had one-year terms, and Thomas Chittenden served 17 one-year terms. But he served, of course, I served 6 or 5.5 two-year terms, so he served longer. But half of his time was when Vermont was a republic. So I am the longest serving governor in the history of the state of Vermont. So this is very complicated stuff, healthcare. And so I'm going to ask you, we're going to have a question period at the end. And if there's something I say that just goes right over your head, or I try not to use too many acronyms, write it down, because we're going to have time for questions, and write it down. We're going to try to, I'm going to try not to talk for a whole hour, so we'll leave more than half an hour for questions. I kind of want to give you, well, first let's say where we are in Vermont. Vermont is unique, of course, because we always do it differently. And I like to say, like most politicians, everywhere I go, I carry a little piece of Vermont with me, which in this case is literally true. I have a hip in my left hip that was put in at Fletcher Allen, so I was thanks to Doug Campbell. But we are different here, and many of the views that I have come from my experience in Vermont. One of the reasons I'm not that crazy about the healthcare bill is because we've done better here, and we did it 20 years ago. So let's look at where we are in Vermont today, what rules we have. Our system is basically the same as every other. There are basically 3 forms of insurance, more or less. One is Medicaid, and that is to everybody below a certain income level. We have a special exemption here, thanks to Bill Clinton, and since some of the things Theresa was talking about, we're going to get back to that. The other is private insurance, which you either buy on your own or you work for somebody who gives it to you, and you pay for usually pay for part of it. And the other is Medicare, which is a federal program. It's actually a single-payer program. Then there's the fourth one that involves a bunch of people, and that's the Veterans Administration. The interesting thing about this, the way I mentioned these systems, these are the building blocks of the American healthcare system. They happen for a lot of historical reasons, which we can get into in the question period if you want to, but I don't want to use up time with that. We actually have also several systems, not just by name. For example, for all the yelling and screaming in Washington about a socialist system, we have a socialist system of medicine in this country. It's for all our veterans. The VA is a true socialist system, and it's owned by the government. The people who work in it are employees of the government. It's a socialist system. Canada is not a socialist system. It's a single payer, but it's not a socialist system. So we have a socialist system. We have a single payer. That's Medicare. We have 50 million people in the single payer, more than people in Canada's single payer, because, of course, there are more people on Medicare in this country than there are in Canada, the whole entire population of Canada. And then we have a private sector insurance-based system, which most people are on, particularly between the ages of, say, 25 and 65. In this state, however, when I got to be governor, as all of you know who were here when I got to be governor, I had no expectation of being governor. I got to be governor because Dick Snelling had a heart attack at a very young age, and I happened to be the lieutenant governor. I was actually seeing a patient in my office at the time, which was the last patient I saw, at least for money. I do take people's stitches out still, but that's only to stop them having to go back to the emergency room to have that done. So after about 4 or 5 days of just trying to put my finger in every hole in every dike that was going on as I suddenly assumed the governorship, I had a few moments to myself, and I thought to myself, you never expected this. Why don't you figure out what you really want to get out of this? And I wrote 4 or 5 things down. And then one on the top of the list was healthcare, was universal healthcare. How I thought I was going to do that in the United States from the point of view of a state of 600,000 people is not entirely clear to me, but that was what was at the top of the list. And once a week at least, I used to look at that list of 4 or 5 things. Transportation was on that list. Conservation, land conservation was on that list. Things that are really important. Jim Hunt, who was a governor for 16 years in North Carolina, once told me, he was sort of a mentor of a lot of us, and he once told me when I first got to be governor, he said, you know, 90% of what we do is important. 90% of what we do is urgent. 10% is important. And so the struggle every day in a job like that is to focus on the stuff that's important and not the stuff that's urgent, because the stuff that's urgent, everybody's going to forget in 3 days. But the stuff that's important matters for a long, long time, long after none of us in this room are around. And that's what healthcare is. So when I first got to be governor, we tried to do a massive healthcare rewrite. And there was a lot of talk about single payer and all kinds of things. And what we ended up out of it, I won't go through all the politics, but what we ended up coming out of it was some really substantial reforms, which are still better than what they have at the national level, even with the president's bill. The first is something called guaranteed issue and community rating. This is a very weak feature of the president's bill, but it's in there. Well, in this state, nobody can be denied health care for any reason save two. One, to buy insurance. One, they can't afford the premium, or two, they haven't been here for 12 months. We did that because we didn't want guaranteed issue and have everybody from Massachusetts and New Hampshire come up here because they couldn't get health insurance in their own state to protect our own insurance market. So we have guaranteed issue, and we have community rating. In Vermont, if you go buy insurance, you cannot be charged more than 20% above the base rate of any insurance company. That's called a rate band. It's very small. Ours is 20%. The federal bill that just passed is 300%, which I personally think is ridiculous because, of course, if they can charge a 55-year-old 3 times as much as they charge a 25-year-old, the 55-year-old is not going to be able to afford health care. So if you say it's universal and we're going to help you, you can't afford it, you still don't get it. So we did that 20 years ago, community rating and guaranteed issue. It's why we have a very high percentage of people who are insured in this state. But the most important thing we do, and today, I was in the hardware store the other day, and the guy thanked me for this, even though Madeline Kunin actually invented the program. But we expanded her program, Dr. Dinosaur, to cover every kid in Vermont under 18 years old. The uninsured rate for kids under 18 in this state is statistically 0. Now, it's not 0. There's 3% who we can't find. They don't sign up. And all we did to do that is actually something the president did in his bill. We had a massive Medicaid expansion. We got a waiver from Bill Clinton. Essentially, in this state, Medicaid is a middle-class entitlement for families with kids under 18. So that virtually every single child in this state has health insurance. If it's not through Medicaid, they're making enough money so their parents almost certainly work for somebody who's giving insurance as an employment benefit. So for 20 years, for an entire generation, kids have grown up in this state with health insurance. And I travel all over the country and all over the world. I run into people all over this country who grew up in Vermont and they're 25 years old and they say thank you for the health care program, which of course the taxpayers of the United States paid for. But it makes a big difference. And it's why I think we are now, and have been for some years, the healthiest state in Vermont. Because if you want people to be healthy, I don't think it's enough to start running when you're 50. I think you've got to start being healthy and get adequate medical care from childhood. And in this state, there's no reason not to do that for affordability reasons. Because as I say, there's 2 or 3 people who don't have, percent that don't have it, and it's mostly for bureaucratic reasons. So that's where we are today. We're ahead of most other states because we have community rating, guaranteed issue, and essentially universal health care for everybody under 18. However, one thing we did not do here, and nor has any other health care reform in Massachusetts or at the federal government, we have not done very little to control costs. Costs have gone up at 3 times the rate of inflation here and everywhere else in this country for 30 years. And there's a reason, and this is an important reason to explain what I think is going to happen. Not so much in Vermont. And Theresa and Jan know, contrary to their nice self-deprecatory introductions of themselves, they know an enormous amount. Theresa also worked for Senator Leahy for a long time in charge of health care before we stole her to come up here. And Jan, as you know, was the health commissioner. So if there are specific questions about what might happen in Vermont, I may ask one of them to answer the question, because I'm not as up to date on what's happening here as I am in the rest of the country. So here's the concepts I want you to get. We're just going to do big concepts here. We're not going to get into the nitty-gritty unless there's some nitty-gritty questions. First, why is it that costs go up the rate of inflation? I mean, so 3 times the rate of inflation, have done so for 30 years. Now, if you ask that question, there's a long list of things that people will tell you. Oh, the lawyers sue us, and so we have to do defensive medicine. Well, the drug companies charge a lot of money, and that's very, very expensive. Well, insurance companies are inefficient, and that costs us a lot of money. Well, procedures are getting more expensive, and here nobody wants to say no to anybody, and that's very expensive. All those reasons, there's some truth to all of those reasons. That's not the reason. There's one reason only that healthcare costs are out of control that matters, and that is you pay me, when I was practicing, to do as much stuff as I possibly can. I get rewarded for doing as much stuff as I possibly can, whether it works or not. Now, I don't think there's any higher percentage of doctors that are crooks than there are teachers or anybody else. There's some, but most aren't. But incentives work. So here's how it works with somebody who's, let's just say, an honest doctor who's doing the best they can for their patients. So you come in and you've got something pretty serious, and we have trouble figuring out what it is. Why not do an extra MRI for $8,000? The insurance company's going to pay for it. You're not. Why not, if somebody comes in with a lot of chest pain, let's do a cardiac catheterization. Let's not, let's just get right to it. Yeah, maybe we'll even do a second one. Why? Because the insurance company's paying for it. You're not paying for it. We have a system that pays by the procedure. The more you do, the more I do, the more I get paid. This means, essentially, that we have an illness system, not a wellness system. Now, I know you hear that thrown around all the time. Why is it that our system isn't a wellness system that is paid to take care of people? Because we don't get paid when you're healthy. We get paid when you're really sick. And the sicker you get, the more we get paid. So my belief is that we are never going to control costs. I don't care how much regulation you have. Look, I'm all for regulation. I was in charge of it for 12 years here. We tried to regulate. We didn't have any better luck regulating medical costs than anybody else. There's a reason for this. Why doesn't this happen in the car industry? It doesn't happen in the car industry because if you want to go buy a car, you decide, well, here's what I can afford. Let's go down to the Ford dealer and see. So maybe you look at a pretty nice Ford. You decide, I want some options, and then they tell you what it's going to cost. You say, I can't afford that. And maybe you can't afford much, and maybe you go to the General Motors dealer next door, and maybe they got something, and you look at a smaller car because you couldn't afford it. And then maybe you just decide, well, you know what? I've been taking the bus for 5 years. I'm going to do it for another year and save up. And that's how the system works. That's how capitalism works. It's supply and demand, and consumers have an influence on healthcare costs. Consumers can't do that in medicine. And I know conservatives say, oh, we have to have HSAs and we'll have all these things and you've got to give price transparency. It doesn't work. HSAs, which are health savings accounts, some of you have them, your company gives you some cash and says, you can spend this, and if you really get sick, we'll take care of it, but you'll choose. And the idea is, since it's your money and you get to keep it if you don't spend it, you're more careful about spending. That's true on the cheap level. You decide most of the time whether you really need to see the doctor or not, and so you save $100 by not going and waiting 3 days to see if your cold really is the flu, and it turns out most of the time it's not. So you save a little money. That's not where the expenses are. The expenses are cancer. The expenses are when you need a liver transplant. The expenses are when you have a massive heart attack and you have to go through rehab. That's where the expensive stuff is. Now, I practiced for 10 years in Shelburne. I never one time had somebody with crushing substernal chest pain get off my table and say, Doc, the guy down the street does it $2,000 cheaper. I'll see you later. It doesn't work. And I've always been dying to tell this story at the medical center, although the only 1 or 2 people will recognize who this was, thank heavens. Mark is one of them. He's going to keep his mouth shut, right? This is a true story. The reason I'm going to tell this story is we are terrible consumers of healthcare. It's not because we're stupid or we don't know anything or doctors try to keep everything from us. It's because we're not emotionally equipped to make decisions when our life is on the line and we're worried about our loved ones. If one of your kids got sick, wouldn't you want everything? Wouldn't you say, I'm not asking any questions? That's why we can't make good decisions about healthcare. That's fundamentally misunderstood. It's not like buying a car or a house. So I'll give you an example, because the worst patients of all are the ones that actually know the most about medicine. So I'm a second-year resident. I'm in charge of this coronary care unit for the night. And a very well-known doctor who's passed on now is a chairman of a very important department that has to do with the coronary, that has to do with hearts. I'm not going to say anymore because in case there may be some relatives. This is a very small state, as we all know. And this guy comes in with a massive anterior heart attack and a really big lot of damage. And in those days, we didn't have all the stuff we have today. So basically, we get him stabilized. We put a bunch of IVs in. We try to get his blood pressure up. We put him in the coronary care unit and put all kinds of gauges in. And he's got to be at rest. And we sedate him and all this stuff because we know that he moves around much. He may blow out his wall, and that'll be the end of that. Next day, he does pretty well. We get him all stabilized. The chairman of the department, I'm, of course, terrified. And we stabilize him. And then all the way to, this is when cardiology was on SHEP 3. Anybody remember those days? SHEP 3? Okay. So all the way down at the other end of the hall, 50 yards from the CCU, all the way to the last bed. I'll never forget this. On SHEP 3 is the step-down unit where people are ready to go home after they've been in the hospital. For about 10 days it was in those days. Now, of course, we do much better than that. There's a code 99. There's a patient who's about to leave. She had an arrest. Everybody runs in. People are rushing in. Everybody's pumping, and everybody's breathing, and everybody's sticking IVs, and this and that and the other thing. And down the hall, in a wheelchair, having pulled all his tubes out, rolls the chairman of the department, thinking, who better to know something about a cardiac code than me? One day post-anterior MI. That gives you some insight into the judgment that people have when they're really sick. And that is why we can't make good health care decisions in acute matters that are very expensive. I don't say that we should go back to the days when doctors didn't tell patients anything. I'm not making that case at all. Patients should participate in their care, and I think doctors are much, much better. And by the way, nurses are not a whole lot better because they know a lot of medicine too. And I think the amount of bad decisions you make is inversely proportional to how much medicine you know when you're a patient. Now, why do I tell this big, long story when we don't have all that much time? I'm trying to get you to understand why free market principles do not work to keep healthcare costs down. But there is something that patients do very well, like most of us. They make good decisions when they buy insurance. When they buy insurance, if it's not too complicated, they can start making decisions. And so when you go on the exchange, is there anybody here that needs to explain what an exchange is? Because I'm happy to do it. Okay, so an exchange is this new mechanism that's going to start in October that's in the Obama bill and in the Vermont bill where people go online or with some help. There's actually money in this federal bill called for somebody called a navigator who will help you figure this all out. You go on and you buy your insurance. And most of it's going to be in the individual market. Not all of it, but a lot of it will be. And you'll make good decisions. You'll decide whether it's better for you, on average, to have a big deductible or a small deductible. Medicare, by the way, is not on the exchange. So for those of you on Medicare, you can tune out to this part of the discussion if you want to. Now, you go on, you buy a health insurance policy. And you're going to buy one that fits you the best in terms of how big the deductible is and how much you can afford to pay per month. So that is an area where consumers can have a significant downward impact on healthcare costs. The problem is, though, that you're not in charge because you pay the insurance company, but I make the decisions about how the money gets spent. So the insurance company has to, of course, mostly worry about their profit, too, and they keep raising prices because I keep raising prices, both because I want to make a little more money, but also because I want all the latest gizmos and gadgets, so I think I can give everybody better health care. And by the way, it also helps the bottom line of both me and the hospital. So we need more changes than just having an exchange with transparency insurance markets. I think we need to get rid of fee-for-service medicine. So you no longer pay me by what I do to you. You pay me for taking care of you for a year, whether you're really sick or really healthy. That's called the old name for that was HMO. It was really unpopular. Now, I practiced for CHP. I really enjoyed it. But when HMOs got bought by Wall Street put enormous downward financial pressure on them, and they eventually squeezed patients and primary care doctors, and they hated it. But Kaiser is one of the most successful HMOs in the country. The doctors love practicing for them, and because the doctors love practicing for them, their patients love being at Kaiser. Kaiser's not here anymore because it's hard to make money in the Northeast for a lot of complicated reasons. So when you pay by the procedure, here's the things that happen. When you get rid of paying by the procedure, here's the things that happen. First of all, instead of the hospital investing in another MRI, because it's great for their bottom line, they'll hire 6 nurse practitioners or a couple of internists. Because now they make more money when they keep you out of the MRI and out of the emergency room than they make if they put you in there. There's a big hospital chain, which is very, very good, Baylor in Texas. Baylor had a lot of problems with expenses, and they weren't being reimbursed. So they hired a team of, actually, there's other people. There's a guy in Virginia who did this too, a hospital administrator. He has an on-call team of a few doctors, nurse practitioners, and some fairly high-tech people, including an X-ray person, a portable X-ray person. And if certain people get sick that they know are high-risk people, they send somebody to their house that they call the emergency room in the middle of the night instead of bringing them to the emergency room, because in the long run it's cheaper. And furthermore, people want to stay in their own homes anyway, and they don't want to come to the hospital if they don't have to. So now that we're getting paid by the patient, not by the procedure, we're starting to move towards a wellness system, because if you pay people to run a wellness system, people will run a wellness system. Right now you're paying to run an illness system. But if we switch to pay per patient, everybody makes more money in the system if you're healthy. We finally have a wellness system. So that's the first thing. Now, what does this have to do with Obama's health care plan? I won't go into what I think about the process by which this bill was passed. But the major decision that was made in Washington when this bill was passed was that we are going to reform health care in the private sector. Now, I'm well aware that there are a lot of people in Vermont that don't think that's a good idea, and I was one of them. But the fact is, that's what the Congress decided to do. We're going to have a private sector universal health care system if this works out. Okay, so let's work with it. There are some things the private sector does better than the public sector. One of them is innovation. There are two things you need to know about Obama's health care plan, besides the very specifics about what it's going to mean for you. One is that he created something called an ACO, an accountable care organization, which this hospital is building and is going to be part of, and is probably going to be in partnership with Dartmouth and a bunch of other hospitals to do it. The idea in the legislature, the Congress, for doing this was to create an integrated healthcare system which could do everything from transplanting your heart to cutting your toenails, and it would result in better care because everybody knew what was going on for the whole patient. That was why they created it. What they didn't foresee, because of course legislation always has unintended consequences, is that smart people who were running the ACO were suddenly going to figure out that they could cut out the insurance companies. Because if you control the healthcare delivery system from top to bottom, why can't you go on the exchange and offer your service to the patient without having to pay for a billing department, without having to pay for the insurance profit or the billing department? And that is what's going to happen all over the country. It's already happening in Boston. If you want to know what's going to happen to this, the president's healthcare system, look in Boston. The truth is Romney Care and Obamacare are essentially the same, and they were written by the same people, despite all the hoopla in the campaign. So Boston has Obamacare and has had for 5 years. One of the things that just happened a couple of years ago, their biggest hospitals in Boston got together and they bought their own insurance company. And one of the big insurance companies that didn't get along with partners, this big, huge hospital complex, started buying up hospitals. So now they're going to go directly compete, and they're going to cut out a whole lot of bureaucratic expense that has nothing to do with medicine. And if they start to offer themselves on the exchange for a single fee that's based on the patient, not how much gets done to the patient, all of a sudden they're going to eliminate all the bureaucracy that we were trying to eliminate when we tried to put in a single payer. So that's a huge change that's going to happen over most of the country. Now, this state may be an exemption because you already essentially are building a monopoly healthcare system. You've had one for a long, long time, and it's going to be essentially formalized in ACO. That's not necessarily a bad thing because it will result in people knowing as soon as the electronic medical records get put in place and work satisfactorily, and that always takes some time, it will result in better harmonization of care and so forth. But it also means, since there will only be one entity, essentially, that you're more likely to have a regulatory attempt to control healthcare costs than a market control. But I think eventually that will come here too, because I think it's the only way to control costs. The next thing that's going to happen is going to have a huge effect on Vermont. And that is, and you know, there's lots of hoopla in Washington about whether this is or isn't going to happen. I'm telling you, it's going to happen, and it's going to happen here, and it's going to happen everywhere. When the exchange is going to in effect in October, small businesses that are required to give health insurance or pay a fine are massively going to decide to pay the fine and get out of the health insurance business. I think that's a good thing. but it's going to result in a lot of uncertainty because people don't like change. People want to control costs, and they want this, and they don't want that, and they always say they want change. But then when they're confronted with change, they're a little uneasy and uncertain, and it makes them nervous, and it's going to be hard to adjust to, and it is going to be hard to adjust to. So in October, you're going to see, assuming that exchanges go in place in October, maybe they'll be delayed, I don't know, but it's going to be very soon. Small businesses in Vermont, just like small businesses every place else in the country, are going to stop giving their employers health insurance. And they're going to say, if they don't give health insurance in the first place, they're going to pay a fine, something like $2,000 an employee, and it'll go in. Now, the really small ones are exempt from this, the under 50s. But they'll pay under 50 employees. They'll pay a fine, and then the patients will go on the exchange. Now, they're employees. I think that's a good thing. Not for everybody, but for most people. Because one of the problems with the healthcare system we have is that healthcare is bound to employment unless you're over 65 or unless in this state you're under 18 and you're on Medicaid. When healthcare is bound to employment, it means people are terrified of losing their job. And there have been in this recession terrible stories about people who've lost their job and can't get healthcare. And they can never get it again if they're over 55, because who's going to insure a 55-year-old? In fact, they don't get hired if they're 55, because who wants to put a 55-year-old on your insurance profile? So this is interestingly enough, this is a Republican idea. John McCain suggested this in 2008 in his campaign against Obama. He was right. There were some other things that weren't so attractive about the proposal, but the basic idea was right. And this is going to happen. It was never intended by the people who wrote the bill. But it turns out, like the ACO beginning to take risk, it is going to be a good thing. But there's going to be a lot of bumps in between. One of the things is, for example, if you take a restaurant that pays fairly low wages, their folks are going to go on the exchange. Whether they do or don't get health insurance now for their employer, it's just that the only difference there is whether the employer has to pay a fine or not. And the federal government is going to come in and help them buy health insurance because they don't make enough money to afford the insurance on the exchange. So there's some good things about this unintended consequence that I think in the long run are going to benefit the healthcare system. But we've just talked about a major topic, or segued into a major topic. Who takes the risk? We've talked about a system where the employers are going to put their employees in the exchange. That means the employers are no longer at risk for what happens in the healthcare system. So the risk has been shifted to the employees and therefore the health insurance companies. Today, most of the risk is at the health insurance companies, and then they, of course, pass the costs on to us when they have to pay 3 times the rate of inflation. There are 3 places the risk could be. The first is today, it's on the payer, which is not the same as the user. What Paul Ryan was doing when he talked about reforming Medicare was taking the risk away from the payer, which in this case was the government, and putting it on the patient. That is, he was going to give you, those of you who are over 65, a voucher to go out and buy Medicare. But if the cost went up at 3 times the rate of inflation, guess who was going to be at risk for the 3 times the rate of inflation? It wasn't going to be the government. That's how he was going to say it, but it was going to be you. So that's one model. You transfer the risk from the payer to the patient. And the idea is that free market systems are going to make it work, and you're going to be really smart about how you buy. Well, I think we've already shown that you can't be smart about how you buy health care because it's a commodity that we can't be smart about buying. We might be able to be smart about buying insurance, but not the actual health care. But there's another model. Suppose you took the risk and put it on the provider. Now, it turns out the provider drives the cost. It's not unlike buying a car, it's not the consumer that drives the cost. It's the doctor, it's the nurses, it's the people that are physical therapists. They decide what you get. They don't decide to just do it to you without any of your permission. But you're going to take their advice most of the time because that's what you're there for, and you're worried, and you want to do the best for yourself and your children. So if you take the risk away from the payer, who has no control over the cost, and give it to the provider, who has a big control over the cost, that is essentially what this model of pay by the patient, not by the procedure is. Now, the obvious downside is, well, aren't they going to really stick it to you and not give you the kind of care that you need in order to be healthy? And the answer is yes, that could happen, but it mostly won't, because most people are in business to try. Most people go into medicine not because they want to get rich or they want to cheat people. They mostly go into medicine because they like science and they like people, and it's a great job. That's what, if you go over to the medical school here, you'll find out that's what motivates most people. And that's not going to change. So what's going to happen here is an evolutionary process in this Obamacare bill, is that even though this isn't in the bill, I think where we're headed is a privately run, single-payer healthcare system. It won't be run by the government, but it'll be a privately run system, which is not very different, actually, than Medicare. And I could actually envision a system that if Paul Ryan had thought a little bit more or knew something more about healthcare, could have designed himself, which is to let Medicare people go on the exchange and buy a package, which is a sort of a voucherizing, except that the government, that the providers would bear the risk and not the people who are selecting the insurance. So now that I've completely and thoroughly confused you, I just want to make sure I haven't left off any last. So let me just, actually, first let me check the time and see how close I am to being over. All right, I have 40, I have 40, that includes question time. Okay, so we're almost done. So what's going to happen in Vermont? The answer is I don't really know entirely, and I don't think anybody knows, including the people who are thinking about what to do, because we can't know right now. You're going to see a huge change in October when you go on the exchange. Now remember, first of all, everybody over 65 is completely exempt from this change. In fact, everybody over 65 is going to get a great gift because the donut hole has been closed. The donut hole, for those of you in AARP know, that's the chunk of money that, I think it's the first $1,500 you spend, and after that you don't get much from $1,500 to $5,000. Then you go over $5,000, they start paying for your prescriptions pretty well. So this is a pretty big hardship on seniors who really are kind of barely getting by to suddenly have to lay out $2,500, $3,500 out of their own money. So the donut hole is closed. You'll pay some sort of a deductible, but you'll be able to, there's no more big gap in the medical coverage. That's the big thing that's going to happen to Medicare, assuming we don't have a change in administration. But for everybody under 65, except for those on Medicaid, even those on Medicaid, you're going to see changes. And first of all, you're going to buy your health insurance through an exchange, which you're going to like, I think, after you get used to navigating it. And for those folks who were born after, long after I was, who actually understand computers, which I don't, there are, as I said before, people in the bill called navigators, and they'll be able to help you through. And a lot of them, my guess is that for some of the insurance agents that sell this are actually going to end up doing this. And then for those on Medicaid, you're actually going to see more people on Medicaid. Now, I think that's a great thing. I think I mean, I can't understand these governors who say they're not going to take Medicaid, and I think they eventually will, because their hospitals, now they're not going to get compensated for care that nobody can pay for, and the hospitals are going to, hospital trustees who have no small amount of political clout in any state in the country, they're going to force the governors to take Medicaid. I think Medicaid's a great system. Does it pay enough for doctors? No, it doesn't. But as I say, we have universal health care here in the state for people under 18, and we did it through Medicaid. And it's a very, very powerful, rational way of keeping everybody. It's also, it's run by the state, but it's a single payer. The administrative costs are very low. The fundamental problem is the reimbursement rates are too low. But that's eventually going to get fixed, because if you make the reimbursement rates too low, as they do in England sometimes, there's a political backlash, and then the government has to figure out how to make the system work better for the public. So there'll be expansion of Medicaid to cover some of the adults in this state, because our children are pretty much already covered as much as they were ever going to be. But they're going to cover the adults, a lot single people who are making barely enough money to do anything, who can't get Medicaid now will be able to get that. So that crowd's going to be taken care of. The fundamental biggest difference is going to be in the private insurance market. And as far as Obamacare goes, we're not going to talk about what Vermont's going to do yet, because we're not going to really know until we see how Obamacare works. As far as the private sector, private insurance goes, if you work for a big company like IBM or General Electric or General Dynamics, your insurance isn't going to change at all. You're going to still get the same insurance that you got from your employer. Probably the medical center is one of those. I mean, it's a very large employer. The state of Vermont, I would guess, would be another one where the people who work there aren't going to see any changes because the changes don't really affect very, very large companies unless they try to choose to dump their folks into the system, and they could. And I actually think that in the long run wouldn't be a bad thing, but it's not going to happen for a while for a lot of very complicated competitive business reasons that I don't want to get into unless you're interested in the question period. So those are the big changes, and the way you buy your insurance is the biggest one of all in the private sector. So over 65, not much change. Under 18, not much change. You've already had a great addition, which I think was really important with it, which is the under 26 rule for parents. That was a huge help because, of course, the group of people in America who have the least, age-wise, who have the least amount of insurance is people under 30 for a lot of different complicated reasons. One, they don't make much money, and two, they think they'll live forever. And three, if you gave them a subsidy, they'd buy a Harley with it instead of a health insurance policy, so that doesn't work either. So that one's already in place, and people are, I think, happy with it. But buying your insurance in a different way is going to cause dislocation. And small businesses are going to ask their employees to go buy health insurance through the exchange and pay for it themselves with help from the government and probably some help from the small businesses if they were giving health insurance in the first place. That'll improve the lot of people who are in low-wage jobs, and it'll put pressure on in people who are in higher-wage jobs. The people in the middle are going to be in the most trouble because if you work for somebody who pays a high wage, they're going to keep their insurance probably for competitive reasons. If you work for somebody who pays a low wage, it doesn't really matter a lot because either you don't have insurance or you probably don't have very good insurance. You're going to go on the exchange and the government's going to help you buy the insurance. But in the middle, there's going to be some dislocation, and we have to worry about that. And when I get asked by people in the government, what should we do and what do you think? What I tell them is, let's not push too hard. I know a lot of people in Vermont want to get to a single payer, and it does make rational sense. But let's see what happens when the Obama bill goes into effect. Let's let people have a chance to adjust to that. Let's see how many people are actually covered that way. Let's see where the weaknesses are, and there will be weaknesses, and where the strengths are. There'll be unexpected strengths and weaknesses in this bill. I think it's going to be great for the small business community because they won't be in the health insurance business anymore. And if you run a small business, it just kills you. If you have 10 employees, and you have to get health insurance and pay all those bills and add all that stuff up and figure out every year how you're going to say it's just a disaster. I don't think small businesses should be in the health insurance business. Let them be in the business that they're trying to make some money in, not the business that's making their life crazy. So there are some people who will benefit. But again, there'll be some people who are unhappy. There'll be dislocations. There'll be people who have trouble understanding how the new system works. And this is going to be really interesting, and I'm just going to close with this. It's going to be a really interesting retrospective judgment. People can say whatever they want when you pass the bill. Here's how it's going to work. Well, we've already discussed how this bill isn't going to work anything like how the people who wrote it think it's going to work. But that doesn't mean it's going to be bad. Some of it's going to be worse, and a lot of it is really going to fundamentally restructure the American healthcare system in spite of what they did in Washington, not because of it. But interestingly enough, the private sector doesn't always get it wrong. And in this case, they may actually get it right if we end up paying for healthcare by the patient and not by the procedure, and therefore end up with a wellness system instead of an illness system. Thanks very much. Happy to take questions, comments, and rude remarks. I might ask you to stand up just so everybody else can hear the question.
You talked a lot about the fee-for-service and moving away from that and going to a more procedure-based.
No, not procedure, patient-based.
Patient-based, moving away from the procedure. And through some of my classes, I've learned that the AMA has been really resistant to moving away from that because they've actually defined MHOs as going against the physician's ethical code. And they have some pretty significant lobbying power, and I was wondering how you were going to deal with that or the feasibility of working around such a powerful group to
Well,
make such a
this is why healthcare is so hard to change, because there are lots of powerful groups. It's not just the AMA. There are a lot of groups that have a tremendous amount of power, and they don't all work at, I mean, it's why we keep going and bumping along with the system we have, because every time you try to change, some powerful group says, no, I want you to change it, but not that way. And then somebody else comes in and says, oh, no, but yeah, but not that way either. And so, yeah. So here's the interesting thing about the AMA, is the AMA is actually not that powerful a lobbying group anymore, because the AMA doesn't represent primary care providers. Specialists are not going to like this, because they're not going to get paid by the procedure anymore. Primary care providers are really going to like this, because primary care providers are going to be more valuable to the hospital, which is going to be either the employer or the contractor with all of us, than specialists. Or maybe not, they won't be more valuable than specialists, but they'll be more valuable than they are today. And people will get paid to keep people away from specialists instead of send them to the specialists. So of course the AMA, now the reason the AMA mostly represents specialists is dues have gotten so high and primary care people are so under reimbursed they can't afford to belong to the AMA anymore. I'm not making this up. And then the AMA has gotten so conservative that people in the Northeast and the Midwest won't join the AMA anymore. So it's mostly very conservative doctors who are of a certain age. And they are from the South, and they're very conservative. And so, you know, they don't really represent, they represent specialists and specialty groups, and they do have that point of view. But to say that it's bad medicine is just political exaggeration. Of course it's not bad medicine. That's like saying everybody who gets their care at Kaiser is getting bad medicine. That's a ridiculous thing to say. In fact, there were those that argue if we did a few less procedures, people would actually we'd get better medicine. I'd be one of those. Jan, are you going to do the calling, or you want me to?
We have a couple from the other room, too, so
Okay.
take one more.
Okay. Okay.
How about making all health insurance companies non-profit? It feels wrong to me that health insurance companies make money on the sick people. And quite a few times, well, actually I heard of a lot of people who had certain problems and the health insurance company is not paying it.
This is a very interesting question. The reason is, why do we have for-profit health insurance in the country? Why should we just not get rid of all for-profit health insurance? And health insurance, for-profit health insurance, doesn't pay the way they should. Okay, so I have a bias here, which is the same bias that you have, but I'm going to actually just try to be factual about it. It is true that not-for-profit health care is better than for-profit health care. How do we know that? Because there have been extensive studies that show that not-for-profit institutions deliver better health. I mean, we're not talking about the profit that the 5 doctors on the corner are making for their salary. We're talking about big chains of hospitals and so forth and so on. That is true. Interestingly enough, the state with the worst health care in the United States of America is the state with the highest penetration of for-profit hospitals. I used to be terrified every winter when my older patients used to go to Florida, because they have the most dangerous health care in America. Because they get you in, and this happened to my father, who got sick in Florida, and they run through all this kind of stuff, and they just do it by rote, whether you need it or not, because they're for-profit and they make money. Having said that, there are 2 countries in Europe who have gotten to their universal, because almost every country in Europe has universal health care. The Swiss and the Dutch have a for-profit health care model to deliver universal health care. So I don't publicly I don't spend my time beating up on the private sector. It is true that I have a particular bias against for-profit health insurance companies, because they do exactly what you say, and my wife still practices, and she doesn't take a lot of private insurance these days because they don't treat her very well, and they don't treat doctors very well. At the Fletch, it's a little easier because you have an enormous billing department to fight with the insurance companies. The doctors don't have to worry about it, but it's not so easy if you have a 4 or 5 person practice and you can't do those things. Or if you're a physical therapist or one of the other allied professionals. So my bias is with you, but there's also some fact on your side that we would probably be better off if we emphasize not-for-profit health insurance and not-for-profit hospitals in terms of delivering health care.
Here's a question from the Sullivan Classroom. What is your vision for quality measurement and quality improvement in the health insurance exchange environment?
I actually believe, I know the buzzword is we should pay by outcomes. I don't really know what that means. And I kind of suspect that the people who are using those words may not be too sure either. Let me explain why. So we need, you can have quality measurements, and we need more of that. And actually, you know who the best, speaking of for-profits, who the best at quality measurements are, is the Fortune 500. Because the Fortune 500 are actually the people, with the exception of places like Kaiser and the Cleveland Clinic, have the best wellness programs. Why? Because they know their employees are going to stay with them for a long time. So it pays them to invest in it at 30 years old, so they're not going to be 65 or 55 in dialysis, or 75 on their retirement programs and using a hell of a lot of health care. So they actually do a very good job, and they really do have quality measurements. And they're really tough. I mean, as a somewhat, you know, most Vermonters have a libertarian streak, and I'm not an exception. I know companies, big companies, that have gyms, and that's great, and they give a free membership, and that's great. Guess what? They also take attendance. And if you don't show up, you don't get paid as much. The state police, I don't know if they still have this. I don't entirely disapprove of this. They used to have, and maybe they still do, if you couldn't run a mile in under I don't know what, then you got docked 10%. And if you couldn't meet the physical requirements after a while, you didn't get paid at all because you were asked to go someplace else. So, I mean, we do, let's not blame the institutions and the apparatus for everything. Let's blame ourselves a little bit here too. We respond to financial incentives. It's just people haven't figured out how to do this yet. They're going to have to. I approve of every cigarette tax increase there ever was, because cigarettes kill people, and if you make them more expensive, people smoke less. The single factor that made kids drop their smoking rate among kids drop from, I think, 27 to 20 or something, is the increase of the price of cigarettes. So there are going to be economic incentives, and we're going to have to belly up to the bar and be responsible ourselves. And we can't expect the health system and put quality measurements on them if we're not willing to do the things they ask us for. So, and that includes all the things that, soda taxes and all this stuff. I'm in favor of any soda tax they want to put on there, because it's not a serious food. And I know the grocers will be mad at me for saying this, but, if you eat that kind of stuff, you gain weight, and you may gain too much weight, and you may have your diabetes out of control, and it doesn't contribute anything to your well-being. So there are going to be a lot of things like that. But in terms of actual outcome measurements, here's the problem. Let's suppose I decide I'm going to reward you by how many people come into your doctor's office with diabetes and how many go out with controlled sugars. Guess what? I'm going to do my best to only get the diabetics that are just a little diabetic. Because the ones that are really diabetic with kidney disease and everything else are a lot harder to control. And I don't want the insurance company auditor or the government or whoever to come in and say, well, how come? And the Fletcher would actually be hurt by this, because we get the toughest cases here, right? I mean, this is where you come if the local hospital can't deal with it anymore. So if you're going to do that, you have to risk adjust. Now, there are ways to risk adjust for the fact that your caseload is much tougher than the average caseload elsewhere. But it gets really, really bureaucratic. So I'm very much in favor of measuring outcomes and setting standards and all that kind of stuff. I think if you start linking pay to the outcomes, in most cases, you may do more harm than good. And I want to hear, I'm open-minded about it, because there's some really smart people, Elliot Fisher at Dartmouth is one of them, who are doing a lot of really good work with this. And I have a lot of respect for Elliot Fisher. I am just wanting to somebody explain to me in a really cogent way that anybody can understand how you, if you connect finances with outcomes, how you don't skew where patients end up and risk making their care worse instead of better.
I have a daughter that's interested in primary care medicine, and she's thinking about coming back to the Northeast to pursue this career. Where do you see primary care doctors fitting in relative to mid-level providers, physician's assistants?
Not a problem. There's a project in Greenwood in Shelburne Road, and we'll take it right now.
But is there still the anachronistic hometown doctor in small communities in the Adirondacks in Vermont? Is that going away in favor of these large organizations?
Here's what I think is going to happen. I think it won't go away, but they won't practice independently anymore. They just can't. I mean, in Judy's practice, it's just gotten, I mean, Medicare was always a problem with government regulations. Now the insurance companies are worse than Medicare. To get somebody, you've got to stay on the phone. The doctor themselves have to stay on the phone for 45 minutes with the insurance companies to get permission to get some test or some drug that they need that the insurance company didn't want to pay for. I mean, it's just too bureaucratic. And then malpractice is not generally a huge problem in this state, but it is a big problem in a lot of states. And it's just too much for a small person. So what I think will happen is, and it's happening already. I mean, in Iowa, which is really overbedded, they've lost tons of rural hospitals. That's true actually in a lot of places in the Midwest. And so there are some market forces that are going to make it hard. But I think what I say to kids who want to be doctors is you absolutely do it. There's always going to be a need for primary care people. I do believe that market forces are actually going to cause this business about trying to pay to keep people healthy instead of waiting until they get sick, and that's how you make your money. And if that's true, there's going to be a big demand, much bigger demand than there is today. 8% in 2010, 8% of all the graduates of American medical schools went into primary care. 8%, that's not enough. We do not have a physician shortage, in my view, in this country. We have a terrible misalignment of what we need to what we get. We shouldn't be spending nearly as much as we're spending at the high end. We should be spending a lot more at the lower end. So the only thing I would say to your daughter and to anybody that's going into medicine is try to do it without debt. Kids are getting out of school. One reason that everybody goes into avoids primary care is you're essentially an indentured servant if you go to medical school and you want to practice private care. You come out with $200,000 worth of debt. If you're practicing in Fifth Avenue or Hollywood or someplace, you can pay that off in a primary care practice. But the average physician in Vermont or South Dakota or wherever else, it will never be able to pay their debt off from medical school with a primary care medical practice, assuming they also want to send their kids to college and stuff like that. So, unless you make the economics of primary care better and investing in paying by the patient instead of paying by the procedure is one of the ways to do that, then it's really hard. So I tell kids, try to get through without debt, go to the National Health Service, go to the Indian Health Service, join the Army as soon as we get out of Afghanistan, and they'll pay your way, and that's the way you're going to have to do it. They're going to have to be, well, you just can't go in there and borrow all that money and be a primary care physician. But it's a great profession, and I would do it all over again exactly the same way if I was starting today.
Agree that divorcing insurance from employers is really important. On the other hand, if you do that and the wages have been artificially depressed because of the amount of money that employers are having to spend on health insurance, how is that going to come back to employees? What's the mechanism for that?
That's a great question. Because in our current atmosphere, it may not. With the influence, in my opinion, the overly large influence of particularly Wall Street on the political community, we have a problem in this country. And I don't say this because I'm a Democrat or I'm a liberal. I say this because when the gap between the rich and the poor gets too great in any society, the society becomes unstable. And that is a historical lesson that goes back 5,000 years. And a political ideology or a political party doesn't make facts untrue. So that's going to have to be an issue. Now, the last people that will give up their health care, employer-based health care, are the union movement. But they will have to negotiate this out. I'll tell you what I think is going to happen. I don't think it's going to be as grim as one might suspect. What I think is going to happen, first of all, I don't think any of the big companies who give really good health care benefits are going to touch any of this for a long time. Because they are paying health insurance benefits not just because nobody else will. They're paying, I'm going to make this up, let's just say General Electric is paying so that their engineers don't end up working for General Dynamics. So they have they have an incentive to pay top dollar, especially since these big companies are actually regulating their costs better than anybody else, because they really do have the ability to run wellness programs and so forth. So this process of divorcing employment from health insurance is not going to happen at the top end where this is the biggest problem, where the wage differential is so great that the people could just put it in their pocket and let Wall Street see their great earnings. The bigger problem is what happens, and this is the unfair part. If you have two businesses the same size in Vermont, and this is not uncommon, where one business isn't paying health insurance and the other is, it's a tremendous pressure on the other business because they can't stay competitive. When they give up their health insurance, I don't think there will be a compensatory increase in compensation. Now, maybe there will. It depends on a lot of other things and its business judgments about the competitive position in the marketplace and so forth. And there are a lot of employers in this state who are just great people and will probably hand them a check and say, here's an extra $1,000 to help you pay the health insurance. That's going to happen. I know that people don't think that happens in business, but it does, especially in a state like this where we really are much more of a community than a lot of other states. But your point is exactly one that we have to watch out for. Look, no system is perfect. The system that I just talked about where you pay by the patient instead of the procedure is going to have plenty of problems. We're just talking about how to reorient it so it works a little better for us, but we are never going to talk about a system that doesn't have problems. And you just identified one of the problems, one of the transition problems.
In a pay-per-patient model, are providers going to be reluctant to take on our most fragile citizens who have very serious pre-existing conditions?
Well, the providers won't be reluctant to take on anybody if they're interested in medicine because they don't get paid by the patient, or that's what I was worried about with the outcomes. You know, if you just measure it by outcome, obviously people who are most fragile are going to have worse outcomes, and so that's why you have to be a little bit careful about that. Most of the doctors are going to end up on salary, and so you know, they don't get paid any more or less because you're healthy or you're sick. There's more work involved, but if you don't want to work, you shouldn't be in the profession. And interestingly enough, I mean, doctors are not immune from the temptations of everybody else. Kaiser actually has a salary structure which partly depends on how many hours you work and how many patients you see. It's not a perfect world. It's not that you got to run everybody through in 6 minutes, otherwise you can't make enough money because it's all fee for service. But they do have incentives because, you know, we are human beings and we respond to incentives like everybody else. And you know, if I could get paying the same for going out and sailing on Lake Champlain in the afternoon than I would staying in the doctor's office, it's not going to be hard to figure out where I'm going to end up eventually. So, you know, again, it's not a perfect, pure system designed in a think tank. You have to design it in the real world based on your experience. And of course, work ethic is different, too. I happen to think, because I'm a terrible Vermont chauvinist, that the work ethic here is great because I think we're all connected to each other in ways that it's not so true in big cities. So I think we feel most of us, not everybody, obviously from the embezzlement cases that we've seen in the free press, this isn't entirely true, but for the most part, we think we have a responsibility as a human being to the people that we're working with, more so perhaps than in some other parts of the country. And hopefully we won't succumb. But we do succumb because we are, after all, human beings, and every system has to have rules to make sure that we don't succumb to those kinds of temptations. But I think, again, most of the time, that won't be a major problem.
We're going to give you another question from the Sullivan Classroom. This is a request for you to comment a little bit more about the other major influences on healthcare costs, like lifestyle choices, food and diet, obesity, type 2, lack of exercise, too much computer and TV time, junk and sugary foods, too much time in cars. Anyway.
Okay, so this is actually a really great question. We talked a little bit about this before. I really appreciate whoever it was that asked that question in the Sullivan Room, because it named lots of things, and they're not all the same. So I have a friend who he was in my class at medical school. He was an MD PhD, which means he was 500 times smarter than everybody else in the medical school. And he's had his own lab at Massachusetts General for his career. And he was finally, now I can talk about this publicly because he's been in the paper, in the New York Times, in the journals, and he does research on obesity. Now, most of you are old enough to remember when alcoholism was considered a moral failing. And we were kind of on the cusp of that when we were training. We were just trying to learn that it was really a disease that you had to take a disease model of it. And, well, today I would guess that most people, including possibly the questioner, thinks that obesity is a moral failing, that this is just people who don't have the willpower to resist going buy a Kentucky Fried Chicken without stopping in. And what my friend Lee Kaplan is doing is looking at the idea that, in fact, this is a peptide abnormality. And in fact, that when you have, for example, stomach stapling or reduction to help with morbid obesity, in fact, it's not actually the reduction of the appetite and the intake, it's a peptide changes in the gut that modulate the brain's desire to eat, which means essentially that obesity is not a moral failing, that in fact it's a disease like cancer or anything else. So So the question is, if you're going to, and I'm saying that just as a cautionary note, I actually believe that the questioner's got his finger on, or her finger on something that's really important. But if you take that attitude towards everything, you're going to make a mistake. I've actually had congressmen, I won't tell you what party they were in, say that if people get cancer, they should be charged extra. I mean, you know, please. So you just got, again, this is like everything else, there's a balance here. So I think there's a balance in the approach to this, because if we don't deal with this question, we are not going to succeed. Because the story of a democracy is that as long as we can make the politicians bear the responsibility, that we can keep doing what we want without consequence. And there's a lot of nonsense. Just, if I'd been on Bill Maher, I probably would have said something else. But that is nonsense. I mean, one of the biggest problems in our country is not that politicians won't talk to each other without screaming and yelling. It's that we won't take responsibility for our own actions. And we do have to admit that. I don't care where you are in the political spectrum. So that's why I think we ought to tax the hell out of sodas. I know the governor didn't want to do that because he lives on the border. But, you know, people still buy beer here. I don't know why they wouldn't buy soda here. I think we ought to make stuff that's not so good for you more expensive. I know that what Bloomberg did in New York or tried to do was controversial. And maybe we don't want a nanny state. But I'll tell you one thing that worked in New York. I am a complete chocolate addict, I confess. And I was killing time around City Hall in New York because I had an appointment. So and I had half an hour to kill. So I went into a Starbucks, and I was going to have my lovely morning breakfast with a large hot chocolate and a big scone. And I was really looking forward to it. I hadn't eaten. It was about 9:30. And I went in, and I started to order, and I looked up, and it said large hot chocolate, 600 calories. Blueberry scone, 550 calories. So I got a cup of espresso for 10 calories. And, you know, so, you know, probably it's a really good idea for the government to require we put how many calories we're eating, because that does help people. And it doesn't cure the whole problem, but there's things like that we ought to be doing. So the asker of this question, this is in some ways the most important question that's been asked, because it allows us to look at our own responsibility. And I think we got to be careful not to give people responsibility for things they can't control. And that will, and so on the list, the things that are on that list will surprise some of us. But I also think to say that we can't control any of it is a total cop-out. And I think, and you're already seeing, as I said before, you're already seeing Fortune 500 companies that will give free memberships to the gym, and they'll dock your pay if you don't show up. Taxes going up on sodas and cigarettes and other things that aren't good for you, and that lead to bad outcomes. And that's another way of using financial incentives, which are the strongest incentive of anything, to get people to behave in ways that make it cheaper to take care of us all.
It seems like there's two. Thank you. It seems like there's two parallel healthcare systems that are afoot. One here in Vermont, and then of course the one we're calling Obamacare. There's been some question about whether the work we're doing here in Vermont is going to kind of be I don't want to say a step in the wrong direction, but something that as we approach it aggressively, we may be better off waiting a little bit to see what comes down from the federal government, in part because we're setting up a system that we may dispense with or may not, you know, survive after the full federal program goes in. Have you any thoughts on how these are going to dovetail or come together?
Sure, I do. And although, you know, if Theresa or Jan would want to butt in on one of these, I would be happy. My own view of this is they are likely to dovetail successfully. I also, as I said before, I give advice to the people who asked for it in Montpelier that they ought to do exactly what you said. Let's see how the Obamacare one goes into effect. But in the meantime, it takes a long time to ramp up to a single payer, which is what the governor wants to do. And so we ought to be making those plans and figuring it out now. They've already done some things that are actually, I think, going to be very helpful in preparation for the single payer, but they're going to affect how the Obama plan goes into effect in Vermont, mostly for the better. I think our exchange is going to be better than the federal exchange as a result, for an example. And I think they've done a lot of good work with both the hospitals and Blue Cross Blue Shield around some of the issues. I don't think they've gone far enough, but I think they're making progress. So if you ask them to wait till after the Obamacare goes into effect, that's just putting the day of reckoning so far down the line that it doesn't make any difference. From my understanding, I do think we have to wait until we actually pass the law. I don't think we should be waiting to do the work. Because I do think there'll be some unexpected things when Obamacare goes into effect here. But I do think, having looked fairly carefully and been briefed a few times, but not understanding as well as either Jan or Theresa, I don't think, that the two are in synchronous, and they're the kind of parallel paths that you can bring together. I mean, it's clear to me that even in Vermont, where our costs are lower than they are in a lot of other places, that the administration costs in a single payer are so much lower than they are in a for-profit insurance-based system that there's not any question. My question is, with an ACO model, does the private sector wring those costs out so you don't have to use a single payer? And I don't know what the answer to that is, and I guess we're going to find out. Do you guys want to chime in on this, or are you all set? Okay. Doctor first. The only guy that gets more television time than the governor. And a much better doctor than the governor.
15 years ago, thanks. 15 years ago, we were having the same conversation. It was just a different room. It's exciting that now we're on the verge of the system changing our lives. It's very exciting. I don't think we ever thought it would really happen, but it seems to be about to happen. You say an ACO leads to consolidation and specialization, and leads to a system that will provide us administrative savings, not unlike the Medicare system. We are all talking about costs. Would you address outcome?
It's not Dr. First, is it?
No.
I had to put my glasses on.
But we had the conversation many times anyway. What will consolidation and specialization in the short run, will we be able to get the same quality of care that we're getting? I understand we'll have tremendous administrative savings like the Medicare system, but will the quality of care be the same as we consolidate and specialize?
I think it will. Look at this. Think about this statistic. Our cost relative to the next most expensive country is about 70% higher than Canada. So we could squeeze, in theory, 70% of our costs out and still have the same quality of care, more or less. I think we're not going to do that. But there's a lot of, I think actually, leaving aside the cost issue, I think we simply do too many procedures on people. I think people get cardiac catheterizations that they don't need and stents they don't need. I think they get MRIs and CAT scans they don't need. And part of the reason is, A, we get paid for it anyway, and B, if somebody else is paying the bill, why don't we just get that little extra piece of information? And most of the time, it turns out the little extra piece of information either isn't there, or wasn't necessary, and sometimes it actually creates a really bad problem because you discover something and you treat the hell out of it and it never needed to be treated. We're having a big, as you know, debate about prostate cancer and whether we should even be doing PSA screening in older men, because if older men come down with prostate cancer, it's overwhelmingly the fact that they die from something else, because the prostate cancer, generally speaking, moves very, very slowly. So I would argue, many people have argued who are more knowledgeable than I, but I think they're probably right, is we do too much medicine in this country to keep people as healthy as they should be. So yeah, do I think consolidation, do I think we ought to do less of all those procedures I mentioned? Absolutely, and I think we'd actually be healthier for it.
Don't want to make this too much about me, but I'm a self-employed, moderate income sole proprietor. And what you may not know is Blue Cross Blue Shield actually just wrapped up a presentation over at South Burlington High School for Catamount participants, trying to advise us what's ahead. My wife just went to that. Have you got any predictions on how this is all going to shake out for the self-employed?
I think it totally depends on income. Now, I don't know, the Catamount they got rid of, right? And they're going to put Catamount people in the exchange? Is that how that works?
May I clarify, self-employed Catamount with no premium assistance?
Right, which means it's very expensive.
Right.
Yeah.
Also an effort to help in your case, but there's also an effort to make sure that the subsidies that were available for people on Catamount Health will also be available. So there'll be supplemental help that Vermont will pay for that is above and beyond what's available under the federal exchange program.
So the answer is, unless Vermont puts up some money, you're in trouble.
Governor, there's always been a sense of urgency associated with healthcare reform and cost control, and I know the governor talked about $1 million a day, that was being was the cost of delay. I wonder if you can speculate if accountable care and shifting the risk to providers and some of the other things that you've talked about are actually going to be the solutions or part of the solutions, what's the window of opportunity here? How long before we see it start to bend the curve? And, is there the political will, in your opinion, to wait for as long as it might take if it's going to take more patience than we heard you had in the opening presentation?
I've got more than I used to have. Well, I've actually have less patience with a TS and more patience with a CE than I used to have. It's a great question. Part of the reason this is a complicated question gets into the role of healthcare in our economy. Healthcare is by far the largest industry in our economy in terms of the percentage, other than if you take all government expenditures together, in terms of the percentage of our GDP that's healthcare. And it employs, this hospital is one of the very largest employers in the state. I don't know where it ranks, but it's a huge, and it's pretty good jobs. So one of the reasons that the healthcare system isn't suddenly turned upside down to save money is because, of course, that has consequences, because saving money means less people work here and so forth and so on. So it's actually not, I wouldn't recommend a gradual 30-year bending the curve, because that's what's happened so far. But bending the curve and not trying to bend it overnight is probably not a terrible thing for trying to refurbish our economic drivers, and this hospital and the healthcare system in general is one of them. In this state, this is the worry I have about Vermont. In theory, when you get multiple ACOs competing with insurance companies, consumers, remember we said I didn't think consumers were very good at buying health care, but they're pretty good at buying insurance. So if you have a competitive system with an ACO which has wrung out all the administrative costs, or a lot of them, in the billing and then the unbilling, because basically insurance, the hospital has a big department that upcodes everything, and the insurance company has a big department that downcodes everybody and then tries to figure out who they can get away with not paying, which is true, unfortunately. It's not clear there's a lot of incentive to have that happen in the model here, because this is a monopoly. So you still may go under a regulatory model here, in which case you've got a political problem, and then and politicians haven't been terribly good at dealing with this. I do think in this case, and this is one of the things I like about Obama's bill, although I don't think it took me a long time to figure out that this was what was going to happen, because nobody in Washington had any intention of this happening and didn't think about it. Obama's bill is actually going to allow the free market to start to push down healthcare costs. Nobody's figured out a way to do that yet, and I think the people who wrote the bill didn't figure out that this was going to happen. But there are going to be some smart insurance executives and hospital executives who are going to figure out they have to do this. Actuarial expertise and reserves in a hospital would allow them to compete directly with insurance companies without these two upcoding and downcoding billing apparatuses that they have. And that's going to happen fairly quickly. It's already happening in Massachusetts 5 years after that bill passed, and that's a big state that's hard to turn around. Here, it may not happen that way, because you're going to have basically, it's a different model. It's more like a single payer, because you have a government, it's not a government-run system, but it's going to be such a big monopoly system. The government's going to have a much greater hand here, and it's going to have to make it work. Luckily, I happen to believe this is true, that no matter which party is in power here, the government is pretty well run in Vermont. I do really believe that this place has been pretty well run relative to other states. And so, and because it's a small community, I think a regulatory apparatus won't be as mind-numbing and blind as it is in some of the bigger states, because we can actually call up the hospital executives and bring them in and try to work together and figure out how we can make it work. So I'm reasonably optimistic, but I don't think you're going to see any sudden changes here. You're going to see some disruption, as the gentleman who worked for himself and had his business, his life is going to be disrupted when this happens. But I don't think you're going to see any major societal changes all of a sudden because of this bill or because of what's happening in Vermont.
We're going to give you another question from the Sullivan classroom. What are we going to do about dental care, which Green Mountain Care Board left out of health care?
I can tell you what our approach was. Dental practices are very different than medical practices. Even though dental practices are essentially small businesses, and they're actually a high capital-intensive small business relative to the income of the dentist. I mean, in other words, a lot of investment in equipment is needed up front, which is mostly not true in medical practices, particularly primary care. It is true in high-end specialty practices, which is why there hardly any more high-end specialty practices that are independent of hospitals anymore. So the question is, do you want to use the medical system as a template for how you think the dental system should work? And we faced this when I was governor, and we decided not to. We decided to let the dentists continue to practice the way they were. And it's much more of a small business model. For example, one of the problems in dentistry is Medicaid does pay for dentistry, particularly for kids, but Medicaid under reimbursements. If you under reimburse in a doctor's office, they usually can switch the costs around and shift them around so they can still see patients on which they essentially lose money. You pretty much can't do that in a dentist's office because it doesn't take a lot to underpay the dentist where they can't pay for the big loan they took out to buy all the expensive equipment. So what we did in Vermont when I was governor is we began to put dental clinics that would only accept Medicaid into the school systems. And we did it in about 5 schools, and I have no idea what's happened to this since I've left. But we did it in in areas where they're low. We had one in Brattleboro. I can't remember if we had one in Burlington. We had one in Bennington. And we'd use retired dentists who just loved practicing dentistry and weren't looking to make $1 zillion. We'd equip the entire thing so there'd be no upfront cost to the dentist. And they'd get, because you can make a living as a dentist on Medicaid as long as you don't have to pay for all the office expenses. We paid for all the office expenses and the machinery. And so that was the way because dentists are reluctant to take Medicaid because if they have a big Medicaid load, they lose money, which you can't do. And so we decided to leave that model in place because I think for the most part dentistry works now. Now it may be that we have to shift the model sometime, but I'm not a big fan of taking models that are working reasonably well and just changing them for some ideological reason. And we didn't. We decided that we would support the lower end of the population, particularly children, and in these ways. And frankly, getting that patient load off the dentist was helpful because then they didn't have to worry about people. This is a population that disproportionately doesn't keep appointments and has trouble with transportation and so forth and so on. And they could substitute patients who paid more, and they'd make more money, and the kids would still get taken care of, and everybody, it seemed to work. I don't know if it still works or not. I mean, I don't mostly work here, and I'm not the governor, so I don't spend time with all the different constituency groups that are important to listen to. That was the model we chose to use for whatever, and if it's still working, I think we should continue to support those at the lower end. And having them in schools is perfect because that's where the kids are, more reliably than any place else. There's not any problem with broken appointments and people who can't, car breakdowns if they have one and all that kind of stuff. And there are enough people who love dentistry and who don't want to work full-time anymore and made a decent living, and so they'll contribute at a cut rate, essentially, their services. And it worked really well here when I was here, but I don't know how that's working now.
I attended a meeting at which one of the administrators of the new program in Vermont discussed the development of it, and at one point made it clear, to me anyway, that Blue Cross Blue Shield, GE Healthcare, United Healthcare would be gone from Vermont, and we'd have one payer, namely Green Mountain Care, ultimately by about the year 2017. Now, that seems to me to be in conflict with what you said about large companies such as General Electric, IBM, the university, that these large companies have a great incentive to maintain paying high premiums to keep their employees and to keep them healthy. It seems to me if it's all going into this Green Mountain Care, are these large companies, GE Healthcare being the big question in my mind since they already are an insurer, how are they going to fit into this program of the single payer being Green Mountain Healthcare?
Well, first of all, I don't want to...
Except that I do understand Medicare is out of it.
Right, Medicare's out, doesn't play any role in this. That's the same system for the foreseeable future. So, I can't answer your question because I wasn't at the meeting and I didn't have anything to do with designing the single payer. But here's what I will say. First of all, I wouldn't say that Blue Cross may end up being the single payer. I don't...
They're saying it's going to be Green Mountain Healthcare.
Well, somebody said that, but there's a lot of talk in Montpelier and nothing's been voted on yet, and certainly nothing like that. So I have no doubt that your version of the story is true. I think somebody probably did say that. But there are a lot of things that have to be voted on and changed and done before we get to that position. So my own guess is that nobody's going to be in a big hurry. And the other thing, that the companies that you mentioned, the big companies, actually don't pay big premiums because they're almost all self-insured. In fact, they are all self-insured because that's one of the, this is very complicated, which I apologize for. There's a federal employee retirement system called ERISA. And it basically says that the federal government sets all the rules in all 50 states. This was put in so that big companies who did businesses in lots of different states would all play by the same set of rules. It is actually illegal for the state of Vermont to tell IBM or General Electric that they have to pay into a system like that and have to get rid of their health care because they don't have any. We have no control legally over the federal retirement system, of which these multinational companies are all part of. So there's a lot of things that have to be done for. That may have been somebody's vision about how this is all going to work, and maybe it will. But there are a large number of things that have to be ironed out, and that is not you have to get in order to get an exemption from ERISA, you'd have to get Congress to do that. I think Congress is not in the mood to pass anything, and they have been for quite some time. So anyway, I think your question is a good one because I have heard these things too in the papers, and I've heard television or radio ads about them. But I think that what people are saying today is not the same necessarily as how this system is going to work. And I think we ought to proceed, but I'm not in any hurry. And I would advise people not to be in a hurry to force the big multinationals into the Vermont single payer. If they're doing a better job and a comprehensive job and they're not going to cost us any money, fine. Now, the question is, how do you fund it? And that's one of the big issues. Do you make them pay a payroll tax, whether they're people are, which you can't do, actually. You have to call it something else because it would be a violation of the law. There's a lot of really, really complicated questions, which we can spend a lot of time speculating about. But the truth is, there's been a lot of talk, and my advice, and has been consistently, and now, of course, is public, is that we ought to not to make final decisions about things like that until we see the full rollout of Obamacare, because there are bound to be some surprises that we didn't anticipate when we get there. I do think Vermont's exchange is going to be a pleasant surprise, but I think the implementation of the federal exchange, which is going to have an effect on Vermont's exchange, is going to provide plenty of bumps. And you'll see lots of unpleasant letters to the editor about all kinds of people who get to be blamed for this come October or November, whenever it goes in. So your question is well taken. I've heard those things too. I've learned not to panic too much about what somebody says at a meeting, because when you actually sit down and draw the lines on the piece of paper in the governor's office or wherever it gets drawn, you suddenly find some really smart people with some objections that can't be answered, and you have to do something slightly different than what you thought. And I want to thank Jan and Theresa for being two of those smart people to stop me from doing bad things.